Are you one of the millions with a health condition that requires you to use needles? If so, please listen. Disposing of your needles properly is a big responsibility. Accidental needle sticks in the home can injure family members, children, and even your pets. I am Dr. Drew Pinsky, and I have an easy solution for the safe disposal of needles and the end to accidental needle stick injuries. You may have heard about Sand Mini. The Sand Mini is the affordable, foolproof way to dispose of needles. It's FDA approved, and with Sand Mini, it is easy. Just insert the needle, press the button, and in seconds, the needle is incinerated. Now you have a needle that is completely safe to discard. No sharp points, no bacteria, germs, or pathogens. Make sure your home and business is sand safe. Every needle, every time. Go online right now and use our special promo code DREW2020 for our best offer ever on the Sand Mini. That's nomoresharps.com, and remember, use my promo code DREW2020 for our special offer.
Hey everyone, it's a dose of Dr. Drew.
And welcome back, everyone. We appreciate you being here. I am on the stream with you all. Thank you, the Vapist. You're back. Dustin, thank you. Happy Tuesday, everyone. Rather than get into any data today, which is essentially unchanged, let me welcome in my guest, Dr. Yogendra. Dr. Yogendra is an anesthesiologist. He's the founder of ECA Wellness. He can tell us about that in a second. And we're going to talk a little bit about, first of all, stuff you review, and I know on your YouTube page, but we'll just talk a little bit about novel approaches to the treatment of COVID. How about that? Welcome.
Thank you, Dr. Drew. Really excited to be here. Just wanted to say, as a Gen Xer, growing up when I was in high school and college, I remember watching you on TV. So most of my friends from my generation, when I said I was going to have an opportunity to talk to you, they're pretty excited. They said, the Dr. Drew. I said, yes, the one we grew up with. So
same dude. He's still alive and still out there trying to make sense of things. So yeah, well, thank you for being here. I appreciate it. And thank you for what you've been doing on YouTube. Tell people about what they can find at your YouTube site.
Yeah, so I initially started my, I'm a board certified anesthesiologist. I sort of have my hands in a couple of different cookie jars. One of them is a sports performance lab that I happened to build out earlier this year, and then COVID happened. But I do practice clinical medicine, despite some rumors out there that I'm not practicing medicine. But I do this on the side. I work with different athletes. I take some of my skills from clinical anesthesia with exercise physiology, create workout and programs and nutrition, and just something I've always been passionate about, and sort of made it into a business.
Thank you. Good. Congratulations. Should people go to ECA Wellness? Is that how they find it?
Yeah, it's the website is the ECA Wellness, and that's on Instagram, ECA Wellness. We do a lot of sort of data-driven, science-driven fitness and exercise programs.
Okay. Now, what I want to get into is a discussion about novel approaches to COVID-19. You had a couple of videos about that up on your YouTube site as well. Where should we begin this conversation? We start with what has been approved already, such as the antivirals and hydroxychloroquine, these things, or at least things that are readily available. Talk to me about that for a second.
Yeah, absolutely. I think it's really interesting that you bring up the antivirals. Initially when the pandemic happened early on, we didn't really understand the disease prognosis. I believe we are seeing these increased cases in certain part of the country. That is the truth. That's a fact. But we're also seeing the number of deaths are declining too. And I attribute that to, I think, the medical community in general. So we have a better handle and understanding of COVID-19. I think when this pandemic happened, we were using old paradigms and thinking it's like an influenza or a common cold. You get cold, after a couple of days you get better, or you feel pretty bad, and after a couple of days you get better, and then off you go back to how life was before. But I think we have a better understanding of COVID-19, where when you're looking at the management early on versus now, I can see just how much dramatically our approach has been. I like to look at COVID-19 as 4 different phases. And if you asked me maybe about 2 months ago, I would have said 3. So that's just wanted to illustrate how even for me, I'm sort of understanding things better as I speak to researchers and doing my own research. That is sort of changing too. And maybe a month or 2 down the road, that's going to change too. So and again, it's very easy in medicine to play Monday morning quarterback and say,
Sure.
well, 3 months ago, we were all saying this, and how come you're saying this now?
Right. That's the way medicine works.
Exactly. And I always tell people the biggest critics are not social media and the general public, are our peers in medicine, Dr. Drew. I don't know if you would agree with me or not.
100%. That's how, but that's true in any scientific endeavor. I mean, that's it. That's how we all strive towards the truth.
Yeah, absolutely. So I'm always very cautious about what I'm saying in social media. I probably think about it 100 times because then I know I'm going to get a phone call. I'm going to walk to the hospital the next day and someone's going to call me a quack or some horrible term. Yeah. But these 4 phases of COVID-19, just the way I sort of broke it down was there's infection, there's viral, there's an immunological, and most recently I started to appreciate a post-infection or post-inflammatory phase, which some researchers are calling it long haulers. Now, when you look at the infection, what we know so far, it's a respiratory infection. I mean, that's sort of common knowledge. COVID-19, the coronavirus, it's got the spikes on it, causing the spike protein. You get infected. The ACE2 receptors on your respiratory tract. We know all of that, but there's a group of people that are asymptomatic. They're getting infected, they're getting exposed, but they don't know that they've gotten exposed unless they've gotten a test. And then a lot of times I found it's usually it's work related. We see a lot of professional athletes have gotten tests and they get on social media. I think Kevin Durant got on and said, I'm perfectly fine. I was playing basketball and lifting weights. And then the NBA forced me to get a test and I found out I'm positive. Right. And I know, personally, I know a lot of people like that. So that's that first phase, but a certain group of people will then progress to what I look at it as the viral phase. And this is where the virus starts replicating. In terms of the symptoms, this is when patients are going to have the increased fever, the loss of taste and smell, the myalgias, the fatigue, and even in some cases, diarrhea. And this is where, when we start talking about antivirals, I think this is where this is where you would sort of plug it in, medications like hydroxychloroquine and remdesivir. Now, the thing with hydroxychloroquine is, I talked to Dr. Zelenko about a week ago. Really got a chance to pick his mind on my YouTube channel. I was sort of one of those doctors that was very critical about hydroxychloroquine in the very beginning. And I was sort of looking at things from being an anesthesiologist. I sort of look at things from an ICU perspective, not so much an outpatient or a clinic. And I started to realize that hydroxychloroquine was not playing a key role, wasn't playing a role in an ICU. And I think, like many other physicians, we just came on and said, well, it doesn't work. Well, I think, now that we understand about the disease and the prognosis or the progress of the disease, I think it does have a role to play. It's just we were putting the medication in the wrong place in that timeline.
Well, you were testing in the wrong place. As somebody working in the ambulatory environment, I assure you, they were using it not just therapeutically, but and continue to use it prophylactically. Most people don't think zinc is the key ingredient. If you test hydroxychloroquine alone, you're not going to get the same outcome as with zinc. So from the beginning, people have been using it. I mean, on the medicine side, it's being used widely. So yes, there's good evidence that it may not be great in the ICU and with advanced disease. Got it. I don't think anybody was intending to use it then.
Right, and I think what with the EUA that was authorized by the FDA, I think there was a lot of panic in the early state. I think we were unprepared. I think the medical and public health departments were unprepared. Even though we knew this was coming. I have a background in public health and worked in the health department years ago before medical school. And one of the things I remember from graduate school 20 years ago was there's going to be a pandemic at some point in your life. So we knew, we were just not prepared. And I think, it's very interesting you brought up zinc, because a lot of these trials that people have been doing, some of them have not included zinc. And talking to Dr. Zelenko, he sort of said, I know he's also talked to you about it, where zinc is sort of that big, the bullet and the gun analogy that he used. And so this is where I feel like maybe hydroxychloroquine and the zinc and that protocol might play a role in helping these patients.
And then also, the remdesivir is obviously also not a panacea. It shortens the duration of hospitalization in people that are very sick, which is good. I mean, that's something. It's not like when you put somebody on Keflex they are magically better in 3 days. It takes a week of IV antibiotics, and we do it because we expect to have resolution and shortened hospitalization.
Yeah, absolutely, Dr. Drew. One of the interesting things about remdesivir, as you said, was it lowers mortality. I think that there was that one study from 15 to 11 days, the hospitalization or the infection period.
Yeah.
But what's really interesting about remdesivir is, let's just talk about the disease for a second. Most people that don't feel well are usually showing up to the hospital around day 6, day 7. Most of the people that I've talked, it's the onset of symptoms. They're just like, you know what, I'm just going to fight this through.
Yeah.
Maybe it's just a cold. They don't want to think about that they possibly have COVID until they're having breathing problems. And then I get that phone call at 2 o'clock in the morning. Hey, and these are my friends. This is like almost on a weekly basis. I have some chest tightness. I put my pulse ox that I bought on Amazon, and it's showing
87.
92.
Yeah. Right.
Yeah, exactly. Yeah. It's like, should I go? So here's the interesting thing about remdesivir. And I'll talk a little bit about this when we talk about some of the other novel medications and therapies. Remdesivir's exclusion criteria is elevated liver LFTs and elevated kidney enzymes.
Yeah.
So it's this, we've got this drug that we can treat in the very beginning, but a lot of people are not showing up till sort of the disease has progressed. At least they're
particularly the liver problems. That's a concern.
Yeah, exactly. Yeah. And what's happening is these moderate to severe COVID-19 patients, they're sort of progressing to the ICU. And when they want to consider remdesivir, there's the exclusion criteria. So it's like this catch-22. We've got a medication that's been approved or got the EUA through the FDA. But at the same time, if we don't really have anything for the later stages, because even if the physician wanted to, there is the exclusion criteria. And I wasn't aware of that until one of my friends of mine, he was an anesthesiologist.
Yeah.
Who I worked with, when he got ill, was intubated in a hospital down in Florida, I was talking to the family about, can you get remdesivir and tocilizumab, the other interleukin-6 blocker? And they said, no, the exclusion criteria. And that was really the first time, when I started to dive into sort of my COVID research, I guess if you want to call it. Mm-hmm. So, in terms of the antivirals, they're sort of the two big ones. I know they've been looking at favipiravir. It's an HIV medication that works. A lot of these antivirals work on the RNA replicase. That's an enzyme that the virus is using. So a lot of the hepatitis B virus medications are blocking that enzyme. So those are sort of some of the antivirals that we have.
And maybe more coming. There's so much stuff. I don't know if you go on the
clinical
trials.gov, you find that there's so many studies going on right now. It's insane.
Oops, my computer's just going in a weird.
There we go.
Weird mode right now.
Susan just put up a thread, our chat thread right next to your picture there. And there's, as you see, if you look at that thread, people want us to get to leronlimab, so we will get there with leronlimab.
Yeah, that's right. That's, we have to. Here's the thing, Dr. Drew. We have to sort of. I wanted to. This is sort of the big discussion everyone's been talking about leronlimab, but in order to lay the groundwork,
I want us to get there. Yeah, I think I want us to get there and talk about all the therapeutics, and then you can see where these more novel and newer things can fit into the story. And so we've been talking about infection. There may be ways to affect early infection. There may be ways to prophylax against infection. Now we're talking about viral piece, which is when the antivirals kick in. I want to jump over the immune and go to the post-immune and just say, if you look at the literature out of the 1918 influenza, the neuropsychiatric consequences were profound, and they were clearly all biological. In fact, Dr. Menninger, who established the Menninger Clinic in Kansas, that's now in Houston, believed that it was the cause of schizophrenia of the day. He saw so much psychotic illness, so much depression, so much neurasthenia, which we now know as chronic fatigue, so much neuropathy and Guillain-Barré type syndromes, that it literally was common, if you survived the 1918 flu, to have long-term neuropsychiatric consequences. So this is
absolutely.
This is the same. In fact, I would argue that this virus has very little by comparison to most severe viral illnesses. I mean, if you've worked with viruses, you'll see it. It's just protean what can happen afterwards. That's where the whole notion of chronic Epstein-Barr and all those chronic viral illnesses, that's where the idea came from. Because long ago, we realized that a bad virus can leave you with a neurological or a psychiatric sequelae. So this is no different. There's really no treatment really in that phase, is there, other than maybe, psychotropics, that sort of thing?
Well, I think it's also very interesting that you bring up the sort of the psych issues. So this is what sort of happened. I got invited to a Facebook. There's a COVID-19 support group on Facebook. There's probably over 1,000 people on there, all over the world. And I just wanted to do almost like this investigative. Okay, let me talk to these people. And I've had so many Skype calls and FaceTime calls, and I was just blown away by these. The number of people that told me all these, it seemed like almost an inflammatory-like picture. Rheumatoid arthritis, a lot of cardiac arrhythmias, breathing problems, people having fatigue, some chronic fatigue syndrome, like pictures of different sort of like myopathies and all this new onset. And something recently I sort of found out is transient hypothyroidism in new onset transient hypothyroidism in these patients. So I started looking at some of the literature from SARS, the SARS-1, and unfortunately, it's interesting when we're looking at these outbreaks. There's always a double-edged sword. You want people to get better, that's a good thing, but on the flip side, from a research point of view, you kind of want them to be sick. I understand there's an ethical, that's that dilemma. Right. As a researcher, you're trying to look at data, but so there aren't a lot of data points and a lot of research from that because they actually did a really good job containing SARS-1. But there's an interesting paper that was in 2006 where Chinese researchers looked at the cardiac complications from COVID-19. And really, they looked at just overall all complications. And what they found was most of these complications resolved after 12 to 18 months, except for pulmonary fibrosis. Right. Pulmonary fibrosis, obviously, it's a long-term or a permanent scarring of the lungs. But what was interesting is this paper suggested that it was pro-inflammatory cytokines that might be a cause of especially the cardiac arrhythmias. Right. So that kind of took me down this path where I went on social media and I started talking to people. And I said, listen, if you had COVID-19, can you ask your doctors to run a cytokine panel and send them to me? Okay. So I probably had about 25 people from all over the world, from Sweden to South Korea, send me their lab work. And it was very interesting. I started to see there were weird spikes in certain cytokines. And cytokines are those messenger proteins that are secreted by the immune cells. And, the paradigm is you have a viral infection, you might have a cytokine storm. You clear the viral and you clear the virus, you get your cytokines, and the cytokines levels should come down. But in these patients, we're starting to see increased levels of cytokines. There's a researcher I've been talking with very closely, Dr. Bruce Patterson. He's probably run about 100, maybe even more assays on patients. And we're finding elevated interleukin-8, elevated interleukin-10, elevated IP-10 levels in weeks and months after after an infection is resolved. And interleukin-6 levels, even though they are decreased, they're not normalized. And I'm seeing also from other samples, I'm seeing about another cytokine called tumor necrosis factor, TNF-alpha. Again, they're not elevated or spiked, but they're not normalized. And these are patients that don't have any inflammatory disease or any underlying condition that might, suggest that there's some inflammation going on. So I think with these increased number of cases we're dealing with, I think the last numbers we saw was 3.9 million Americans that have had COVID-19. I think moving forward as a country and as a medical system, this is going to be a much bigger problem, especially for a lot of our primary care doctors. You mean the
post syndrome, the post-inflammatory syndrome?
The post syndrome, exactly.
Yeah, I'm not surprised. I'm not surprised. And believe me, general medicine deals with stuff like this all the time. These sort of poorly defined syndromes that we cannot really treat very effectively. Maybe we'll come up with something since we're so focused on the immune component of this disease. I'm fascinated by TNF-alpha because is TNF-alpha a major player in the cytokine activation syndrome?
Yeah, so it's interesting. It is one of the major players. When you look at that cascade, it's there's over there are hundreds of cytokines and.
Now, let me just stop you because we're going to get into the weeds here in just a second. But just before we start that, there was a really prominent editorial in the New England Journal of Medicine that sort of cautioned us, and I want to frame our conversation through this caution because I thought it was a worthy way of framing it. They were essentially saying, look, we've known about viremia and cytokine activation in sepsis, in viral disease. It seems to be excessively active in this case, but we don't know for sure that it's not direct viral injury. We don't know that it's iatrogenic injury we're looking at. We just know that something funny is going on that has been called both cytokine storm and cytokine activation syndrome, and that it's probably a major player in this physiology, but we need to have a good deal of a lack of hubris, a lack of hubris? What would the other word be? Just humility as we go forward and look at these things, because we don't know for sure what we're looking at. This is a very complex area. I mean, septicemia. Do you run an ICU? Is that where you're working a lot of the time?
Mostly in the OR, do some ICU
right.
work.
Okay. Well, if you work in ICU, septicemia has been a major topic of conversation for 30 years. I've seen many different incarnations of what we thought was going on and many different approaches to septicemia, many of which have hit the trash heap. So I just want us to be humble as we approach here, because this is a very complicated area of physiology. You can push on one area and you really don't know what you've done in another area. You don't know if you've interrupted the body's ability to, maybe this is adaptive, what we're looking at, and we're going to start crushing an adaptive response. I don't believe so. I believe this is the right place to look, but I just want us to have the proper humility as we walk into this. Does that seem right?
Yeah, absolutely. And just along those lines, we do have this immunological phase, which, I'll dive into in a second.
You and I believe that's true, but I'm not sure it's 100% accepted.
Well, I think there might also be some overlap. I mean, when you look at some of these pathology reports, these ACE2 receptor, where that initial viral entry, you see these ACE2 receptors in the kidney, in the liver, in the heart. You're seeing them in the blood vessels too.
Yep.
So is there, is it a mixed picture? Is it mostly immunological with some viral injury due to those ACE2 receptors?
Yep.
So,
or is it prolonged hypoxemia, or is it some endothelial process we haven't identified yet? I mean, this stuff, still a lot of questions to be answered, but I'm prepared to call it the immune phase of the disease, and I'm ready to say we should attack it. I had another doctor on here. What was Dr. Tom? Help me, Susan. Tom. Don't get an aging brain, Dr. Yo. The ability to bring back names is woefully.
You got me this time, Drew.
Lost. Doctor, he's probably going to be on the stream here, but he has been working on this for. He was one of the first to identify it as cytokine storm, and immediately started using novel rheumatological agents and bringing rheumatologists in and saying, what should we be used given what this is your area of expertise. What should we be using to try to compensate for the activity we're seeing? And he was using a lot of IL-6 inhibition, generalized steroids, and the steroid question is in there. How much steroid, which steroid, when, and which patient, we still don't know really, except we know that 6 milligrams of dexamethasone late in disease is useful. We know that. I've used solumedrol and prednisone early in disease to good effect, in my opinion, not in huge doses, but it really helped, I thought. And so let's go on. So talk to me about the kinds of immune interventions you're interested in and you see.
Yeah, it's right.
Yadigar, thank you. Tom Yadigar.
We start, the whole thing about cytokine storms and the cytokine release syndrome. It's sort of dominating. I think there's a lot more conversation about that. The thing is, implicating or trying to explain how the whole cytokine thing works is it can be quite dizzying. I think I can probably spend the rest of my career trying to, talking to virologists and people that have been, immunologists have been doing this for a while. Even they have a really hard time.
That's right.
So I think we're just only starting to scratch the surface of the understanding behind it.
I agree.
The thing with the easiest way for how I looked at the whole cytokine storm is I look at it like the U.S. military. So we got 5 branches of the military. We got the Army, Navy, Air Force, Coast Guard, and we've got the Marines. So they take care of our domestic and international defenses and our national security. So if we had an invader in the United States. So let's just say the New York is our lungs, Los Angeles our heart, Miami is our kidney, and Dallas is our liver. So if we had an invader, let's say in New York, and suddenly our military would coordinate a response, the army and their branches and their divisions would come in and tell the Marines, hey, listen, we're doing this, and so on and so forth. And they would say, listen, we got the bad guy here, let's go get them, da 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 da. Now, what happens is for some people, and we really don't know the reason why, there's a lot of speculation why some people have this hyper immune response, which is the cytokine storm, where those signals, these cytokines, which are the messenger proteins, they secrete from each cell, they coordinate responses, intracellular, extracellular, they're all about messaging and transport and whatnot. The messages get mixed up, and whether that's virus causing that directly, whether there's some other pathway that we're missing out on. Some have suggested there might be a genetic component. There was a 2015 study in Australia where they looked at, I believe, some infants, and they found a defect, a genetic defect in a certain in the CD8 cell, which is your cytotoxic T cell. There's a defect in the perforin protein, and perforin, as it perforates an infected cell, and it injects an enzyme called granzyme, and it causes the destruction of the infected cell. But there might be a defect in that protein that's now kind of causing this cytokine storm, because it's almost like a cell banging its head against a wall. And it keeps on banging it, and then it kind of just causes more release of cytokines. And that's how these researchers explained it. They were attributing it maybe about 15 to 20%, but there haven't been too many studies looking at the genetics of cytokines.
There was one good one. The New England Journal had, again, another good one where they have 6 candidate genes that are some. It's complicated. You can't isolate cytokine to one gene. It's you can't really do that. But the cytokine and blood type is clearly tied into these 6 subgroups that are at risk, and inflammatory response generally, let's say.
Yeah, I mean, it's very interesting you bring up the blood type too. So there's we've been talking about how the type A might have a higher risk than type O.
Yep.
And I started to look into this a little bit more. I wouldn't call myself an expert by any means, but there's some researchers that consider that COVID-19 is what's called a carbohydrate recognition virus. And they've looked at the spike protein. I think the Max Planck Institute and a couple other big institutes and researchers that found a sugar covering, a glycan covering over that spike protein, which is where a lot of the vaccines and a lot of the therapeutics are targeting that spike protein. But that's a sugar covering. And what the virus is doing, it's hiding itself from the immune system, because most of our cells have sugars on them. They have carbohydrates on them. So this is sort of tricking the immune system into thinking it's actually one of its cells. So I just thought that was pretty interesting, and like in the research I'm closely following. But it's really interesting. The ABO blood type, the ABO antigen system, is a carbohydrate protein. And I remember kind of trying to figure out, how is this working? And I remember from med school being, wait, the ABO system is a carbohydrate. So some was suggesting there might be some sort of recognition of the virus to these carbohydrates on the red blood cell. Again, it's purely theoretical, and it's something that needs to be investigated. But since you mentioned that, I just thought I would throw that piece of that hypothesis out there. But going back to the whole cytokine storm. Let me just say, somebody is responding to your story there, your narrative. Apparently, the glycobiologists have been looking at antifibrotic galactin-3 inhibitors, which is another sort of sugar type situation, which is interesting. So people are on this. Yeah, there was an interesting study from the University of Illinois, maybe about 3 weeks ago. I've been sort of talking with their lead researcher, where they're looking at something called galactin inhibitors.
That's it. Yep,
as a potential therapeutic.
That's what this Mark Rice is commenting on here, and he's saying that there's a lot of work going on in this, and that it may have something to do with ARDS, which is the fluid filling inflammatory process in the lung infection of COVID. Interesting.
It's Dr. Drew, it's very interesting. I probably in the last 2 or 3 months sort of started to dip my toes into this galactin world a little bit and look at the research. There have been there are a couple of galactin therapeutic companies out there. It's very interesting. They've shown in rat models that what we talked about earlier about pulmonary fibrosis, they're able to reverse pulmonary fibrosis in some of these rat models. Yeah, it's really, really interesting. I don't know too much. Like I said, I'm just sort of starting to dip my toes into this.
Yeah,
so I feel like sort of, after, this pandemic sort of gets over, I think it's going to be really interesting because it might have some real clinical implications. And
I feel like it's fast forwarding a lot of stuff. It's pushing stuff into use that we might have taken years to get into common practice, and now a lot of people are getting experience with a lot of these things we're talking about now. So let's go back to the immune response. So people have been using IL-6 inhibitors to some effect, but it's not really clear what they're doing, right? Talk to me about Ccr5 and RANTs.
Yeah. So here's the thing about so before I dive into that, I'm just going to point out that the main thing about this is there's a cytokine, this cascade of medications and the cytokines, and where do we target it?
Right.
This is how I look at it. We're trying to find, if I'm going to use a football analogy right now, if I'm on defense and I've got an offensive, I'm looking at the offense. My goal is to find, as a researcher and a physician, my goal is to find the quarterback of the opposing team. I need to find the quarterback of the cytokine storm, because if I find the wide receiver, that's great, but that quarterback is the one calling audibles. He's going to be able to, know the next. And
to take your metaphor further, and if you find the right wide receiver, you're going to have to also zero in on the running back and on the tight end, and you're going to have to make a lot more defensive maneuvers than just tackling the quarterback.
Which is what makes this a little bit challenging, because I think for the longest time we were targeting interleukin 6. I mean, I think it's probably the most well-researched cytokines implicated in rheumatoid arthritis, and many other inflammatory diseases. I think even some of the cancers. So I think that when they started giving tocilizumab and interleukin 6 an interleukin 6 receptor blocker, I think it was also FDA approved, so it was easy to obtain as an off-label for COVID. I think people were targeting and thinking that interleukin 6 is the star quarterback.
Yeah.
But I've come to realize, just looking at data
early on, I don't think so, and I think sometimes it's a mistake to hit it, and we don't know why.
Exactly. And I think like interleukin 6 obviously plays an important role, because when we start looking at these drugs and the serum markers that we're looking at, we're still using interleukin 6 as a guidance. So I'm going to say interleukin 6 is the star wide receiver, but it's not, again, if you're going to block it, like you said, then we got to block the star running back, and we got the tight end, so again, we're trying to find the quarterback. You knock out the quarterback, it's like you're really knocking the queen bee. So when you're looking at all these therapeutics and these new monoclonal antibodies, researchers are trying to, their hypothesis is this cytokine is the quarterback, and this is where we're going at, and we're able to ruin the offense. So when we're talking about this drug, leronlimab, I've had a lot of interest in it, and it all started with my friend down in Florida, the anesthesiologist. I started to look at some of the other medications when he was excluded from getting remdesivir and tocilizumab. I did my independent research. I will also say I am not affiliated with any of these companies. I don't get paid by them. I always have to run that disclaimer.
Right.
This is all purely
that's why I'm talking to you, actually, because I want to get an objective point of view. So thank you.
No, again, thank you for having me. And so for me, it became personal. It's like, I got to help my friend, Dr. James Mahoney over at SUNY Downstate, where I did my training at. He was on the cover of New York Times and the Guardian newspaper about 2-3 weeks ago. He was my attending in residency. I spoke to his brother the night that he died, just sort of talking about what we can do. And this led me down this, okay, I need to figure out something, because if this is happening to me, this is happening to so millions of people, not only in this country, around the world. And I stumbled upon leronlimab. So that I just also want to point out that all these drugs that I'm going to talk about, they are not, there's no studies. There's no double-blinded randomized control studies. There's a lot of them don't have any really big publications. They've looked at small numbers of very observational studies that we know. And
isn't there something coming out on leronlimab like this week?
Yeah, so they're supposed to be, today they put out a press release about there were no the adverse events from their control versus the drug arm, but they haven't really come out. They didn't say anything about the efficacy.
Got it.
Of it. Yeah, so they haven't released that information yet. So everything that we're looking at is from a 10-patient study at Montefiore Hospital. So since you talked about the Ccr5, I'll sort of backtrack and start from there.
Sure.
So the CCR5 is a receptor that's found on many different immune cells, the T cells and macrophages. And there's actually been quite a lot of research on CCR5. It's a co-receptor in HIV. We know that CD4 and the glycoprotein, the GP120, has been sort of studied extensively for the last 20 to 30 years. But they also found that there's this co-receptor, the CCR5, and that's where.
Did I send you on the wrong path? Is it CCL5 or is that a different receptor?
Okay, so CCR5 is the receptor. CCL5 is Rantes. It's another name.
Okay,
for
Rantes is CCL5. Right, got it. Okay.
Yeah, all these numbers. Yeah, they can start to get confusing after a while.
Well, then an L versus an R, and you're in a different system. So okay, got it.
Yeah, exactly. So it's very interesting how this works. What happens is, again, I'm going to use this another analogy. If you and I were in a room, we blindfolded us, and let's say put a rope in our mouth, and we couldn't talk to each other, and I was in one corner of the room, and I was in a scuffle, and I needed your help. I need you to come over to me to help me out. So what I would do is, you can't see me and you can't communicate with me, except you can smell. That's the only sense that you have. So what I do is I have some cologne and I spray it around me. I'm like, Dr. Drew, I hope you can come over here and get my back, because I'm about to get the crap beat out of me. So I start spraying this, and then you detect that smell in the other side of the room. And the stronger that smell comes, you start getting closer and closer to me until you're right next to me. And then I'm like, okay, I feel you, Dr. Drew. Now let's go and let's just beat this guy up together. But then we realize that, hey, listen, we are not strong enough. We need more manpower. So you start spraying a bit, I start spraying a bit. Now, next thing you know, we got the whole neighborhood is come over to our side, and now we're beating up this guy up. And then, things get out of control. And that is really what's happening with the whole cytokine storm. Is we're beating up this guy. Now we start beating up the wall. We start breaking up the ceilings, smashing the windows and whatnot. So what leronlimab's almost like you're putting a little thing on your nose to pinch your nose so you can't smell. So now when I'm saying, wow, I'm about to get beat up, you are not sensing that cologne. You can't detect it. So you're staying in your corner, just chilling out, waiting for someone to come try to fight you. You're not coming to assist me. So that's really, a very simple way of looking at it.
And a lot of this research was around HIV, right? Originally?
A lot of it's been in HIV, and a lot of it has been in cancer, in cancer research, especially with cancer, with how the whole metastasis works. It sort of uses that sort of mechanism, and we call it chemotaxis, where it goes up a gradient. So the more concentrated the Rantes is, and we can look at it like cologne, the stronger that smell is, the closer you are to your targeted area. What's very interesting is Rantes is secreted by many different immune cells, and it's almost acts like a magnet. And there was a very, and this is the reason why I've been very high on leronlimab. The science behind it is really one reason. That's Dr. Bruce Patterson. I've always called him the Mr. Miyagi of COVID-19. He was on top of this, probably back in January and February, a very big name in the industry. He's the former associate professor of virology at Stanford, and now he's the CEO of IncelDX.
Is he the one that did the TED Talk that's circulating around?
Yes, yeah. He's the one that did the TED Talk, right.
The Rantes, we think about it just in short-term Rantes, but it stands for regulated upon activation, normal T cell expressed and presumably secreted. That's what it's.
Yes.
Regulated upon activation, normal T cell expressed. And is it a series of chemokines?
Yeah, there's several different chemokines, and this particular one, I think Dr. Patterson, he's been in HIV research for about 3 decades now. I think from my discussions with him, he was able to hone in and suspect that this Rantes played a real key role. It's really interesting. It's not a new finding. We know about Rantes. It's been in the literature for about well over 2 decades.
Right. It's back with HIV research.
With HIV research, and also it's also been implicated in so many other pathologies. I sort of did my investigative work, and I found out that Rantes is implicated in liver damage. It's implicated in kidney failure. It's implicated in ARDS. they've been able to isolate rantes. And this is across the literature. And what was really, really interesting is in 2001, the University of Toronto published a paper that rantes was elevated in Kawasaki's. So
that makes sense.
When you start looking at all these things that we started hearing about COVID-19, the Kawasaki's or this inflammatory like syndrome in pediatrics, and especially in New York, when we looked at that immunological phase of COVID, where a lot of patients were going on dialysis, they were having liver failure, obviously the ARDS, we can implicate rantes in all of that. So what leronlimab does, it's a monoclonal antibody that occupies the receptor on the T cell, the Ccr5 receptor. So how that works is when we've got two systems, we've got the innate and the adaptive immune system. So the innate is when we got the macrophages and dendritic cells, which you call the APCs, and they floating around picking up things that not supposed to be in our bodies. One of them is the coronavirus.
Right.
Get this, chew it up, put a little piece up, a T cell comes. Now the T cell, gets activated and goes down these pathways. And what it does is on that side of inflammation, the macrophage is secreting rantes, the T cell is secreting rantes. They want all the rest of their friends coming in, and all of their friends coming in are also secreting cytokines. And then some of them are pro-inflammatory cytokines, and boom, next thing you know, you got the massive block party going out of control.
Right.
What was really interesting about leronlimab that I found very interesting was that there are three important things when that leronlimab does. One is this mechanism where it blocks the Ccr5 receptor. It sort of almost downregulates the entire cytokine storm cascade. The second thing that was really, really interesting that Dr. Patterson in his manuscript looking at 10 patients at Montefiore Hospital, what we found is a lot of researchers have found is that in COVID-19, there is immunosuppression. In HIV, there was CD4 counts were decreased. I think we were measuring CD4 counts with HIV and AIDS. In COVID-19, a lot of researchers, and this was started in China because obviously they had the pandemic first. CD8 we're seeing decrease in CD8 levels. And what some Chinese researchers and also Dr. Patterson have coined T cell exhaustion. And what that means is that basically the T cells are getting exhausted and they're getting depleted. So what's happening is you're losing a very important cell in that immune, sort of it's part of your immunity. So what leronlimab does, it acts as an immunomodulator.
So hold on, let's stay with the CD8 thing for a second.
Yeah.
So these are cytotoxic T cells, right?
Yes, the cytotoxic T cells, yes.
Right. And they are overactive or depressed during viral, aren't they? It seems to me like that would be a general viral response that you sort of depress your CD8 cells possibly. No?
Right. Well, what's happening is that because these cytokine storms are revving up this hyperimmune response, they're all getting activated. Okay. They're all getting revved up. So what's happening is even ones that you don't need are all joining in on the fight, and they're getting exhausted. I think there are markers that virologists and immunologists can pick up to detect that they are exhausted and depleted. So
did you see just a general note? This is a more macro observation that low lymphocyte count on admission has bad prognosis.
Has bad prognosis, yeah.
Yeah, which is interesting.
Well, it's interesting thing, and I think you brought it up earlier. It's the immune system is almost like I like looking at it like it's like a symphony. You got all these different players in it. You've got the woodwind instruments, your strings, your piano, your percussion, and all of them have to play a very delicate balance. And when one piece is off, the whole orchestra, the whole symphony is out of control.
Yeah.
And one of the things people always talk about is giving dexamethasone and shutting the entire immune system down. I like my analogy is the Escape from LA with Kurt Russell, Snake Plissken, the last scene when he's like, I'm going to, shuts the entire world down.
Right.
And that's what dexamethasone does. But the problem is if you shut the entire immune system down, who's going to fight the virus?
Right.
And that's why that dexamethasone study from the UK showed that early part of COVID-19. Right, exactly, because you don't have those cells to that immune response that you need. So what's sort of happening, my understanding is that by what leronlimab does is that by occupying that CCR5 receptor, you're not calling all of these cells in, and you're not having this overwhelming immune response that over time they're just going to get exhausted and depleted. And then that's
Right.
obviously you lose almost like you're losing your soldiers in that fight against the virus. And I think it was really a great point you brought up before our discussion. Again, the virus also might be causing some of this. It might be kind of running parallel with the cytokines. Something I've talked about in my videos is the art of war. Deception is key.
Yeah.
And
viruses are notoriously that way. That's true.
And I might have been focused so much on viruses, and now we're saying cytokines and then forgetting about viruses. And I always, want to point out how important, not to lose sight of just talking about the immunological response. We're also dealing with a virus here, which now brings me to my third point, which is interesting about leronlimab, is in Dr. Patterson's manuscript, he showed that viral loads decreased after 7 days and was normalized, or there were no virus after 14 days. So there's some sort of property in leronlimab that is also acting as an antiviral. And me personally, when I looked through a bunch of these new medications, including remdesivir, I didn't see anyone sort of quantify the viral load and say, like, look, we've decreased the viral load all the way down to 0 in 2 weeks. And part of my explanation is, again, it's as an immunomodulator, using my example with the U.S. military, it's instead of them just bombing out a city because they don't know what to do, you're really modulating them and telling them, giving them direction now and saying, okay, stop beating up your lungs, stop beating up your kidneys, and let's redirect the fight against the virus. And so, the other interesting point about that Montefiore study, one of the biggest criticisms is that they looked at 10 patients at this Montefiore study, and 4 of them died. And everyone goes, this drug doesn't work. Well, if you look at the demographics of those patients, I trained at SUNY Downstate and also at Kings County. I trained at inner city, New York City. When I looked at these demographics and the health profile of these patients from the study, they are the sickest patients alive, or barely alive. These are, all of them were end-stage renal, end-stage liver, COPD, cardiac transplant. They were literally knocking on death's door. Probably without any intervention, it's 100% mortality. So, I think sometimes people think that leronlimab and all these drugs are these magic drugs. You give them and suddenly you are going to get better. It's important to remember it restores the immune system to where it was. So if you're an 80-year-old person with coronary disease, COPD, end-stage renal, you've already got a weakened immune system. Your immune system is not as balanced as it was when you were much younger. So I can restore it to what it is. But if your immune system can't fight the virus, well, I'm sorry, but that's just, we'll have to try an antiviral. We'll have to try some other therapeutics. So I think, a lot of people get excited about these drugs, and they think that, not just leronlimab, but just across the board. They think it's this magic pill. We can get our lives back together, back to what it was before the pandemic. But I think it's really important to remember that none of these are magic pills or magic drugs.
Well, and as is usually the case with viral illness, you end up going at it multiple directions. It's usually not one medication. It's usually multiple approaches to the virus in order to, again, looking at HIV and AIDS, that sort of gives you kind of that similar model, though it was a different issue. The issue was killing the virus and dealing with the infections that were resulting from the immune suppression. In this case, it's killing the virus and dealing with this immune response, we're calling it, or cytokine cascade. How about the hyperthrombosis? Any thoughts about that and where all that thrombotic stuff is coming from?
Yeah, it's really interesting. Again, when you look at some of the endothelial cells, and this is where I don't want to downplay the role of the virus in these, and I think cytokines are also playing a role. Now, I have a couple of I have a couple of hypotheses behind it. Now, your endothelial cells, in your epithelial cells, you've got your ACE2 receptors on there. So there could be the virus is latching on the spike protein ACE2 receptor, causing some, an inflammatory response and causing the coagulation cascade that way.
And yet, if that were solely the phenomena, you would expect anticoagulants to work better than they do.
Exactly. So, we're looking at a multifactorial or a multi-pathology, many different pathways that are taking place. One of the things in my videos and in my social media I talk about is, people always say, okay, the virus is causing the cytokine. I said, no, I'm trying to look for different ways of how cytokines are flared up. And something in my research I found was this thing about galectins. Galectins can directly fire up cytokines in the literature. And where do you see elevated galectins? You see elevated galectins in patients with diabetes, obesity, stroke, atherosclerosis, coronary disease. Now, when people say high-risk patients are having high-risk patients have a increased risk of severe COVID-19, we don't know the reason. Sometimes I'm going, well, we need to be testing galectins. I think that might be something that, we should be throwing in our panels because, again, this is not a hype. I know it's a hypothesis. I'm making that connection, but we know in the literature, galectins are elevated, and we know galectins are also firing up cytokines. So,
the other, I'm just looking up if there's any connection between galectin and antiphospholipid, because antiphospholipid syndrome is those patients that I've seen get COVID just are destroyed by it.
Yeah, absolutely. And I think there's also connections with, what was interesting, and I just sort of came across this maybe about 2 weeks ago, was RANTES is secreted by epithelial and endothelial cells. So it's one of those things is could the use of leronlimab potentially help with this hypercoagulable states?
It makes sense, right? It's a very reasonable hypothesis. There's a study I just found, autoantibodies against galactin-2 as a biomarker for the antiphospholipid syndrome. Interesting.
That's interesting. I did not know that.
So there's something going on there too. Antibodies against galectins are associated with, let's see what this study says. Hold on, one more. Come on. Antiphospholipid syndrome with systemic lupus. But you don't have to have lupus to have antiphospholipid. Although it's called a lupus anticoagulant, that's just what we call it. So it's all, all these things are all swimming in the same waters. That's what's so fascinating about this, that maybe leronlimab is the one connecting physiology there, or biochemistry.
Yeah, absolutely. It's really, I just mentioned one thing, this whole thing is so humbling because you literally on a daily basis, there are no absolute truths in any of this. That's the one thing I've come to realize. We have to throw out all the paradigms and what we thought about before. And almost on a daily basis, we're learning something new. And that was the thing about leronlimab. Again, the science behind it is what fascinated me about leronlimab. And there are also other monoclonal antibodies. And me personally, when I look at, going back to that football analogy, I feel like potentially using more than one monoclonal antibody might be, if not just effective in COVID-19, but also many other possible viral infections, and hopefully we don't have any pandemics in our lifetime. But and there are
random events segregate non-randomly. I hope you're right, but things come in series.
Yeah, exactly. And I think the really hard thing is, a lot of people get very excited about that drug. They become almost very territorial about it. And when I suggest about, okay, listen, we need to start talking about possibly having two therapies, I think people get it's very weird. But I'm a clinician. I don't have any loyalties to.
It's very common in as physicians, we're trying to alter physiology, right? People have to think about what our job is. Our job is to treat disease, which is an abnormal state of physiology, and modify that physiology in such a way as to improve the outcome. That's what we do. And typically, whether it's antibiotics for infections, we're using 2 or 3 agents. Whether it's depression, we're using 2 or 3 different or 4 different approaches to the neurobiology. It's just sort of typical, for whatever reason, that we usually have to do more than one biochemical hit in order to get the physiological change we want.
Yeah, absolutely. I think sort of, moving forward, whether it's a combination of a antiviral with a monoclonal antibody like leronlimab. And again, we don't know. I think it's really important that what we know so far, the science is there, anecdotes are there, and anecdotes. It's very hard doing those double-blinded, randomized control studies. I think there's a difference between a lot of research mind and clinicians like myself and yourself. Is we see patients on a daily basis. I want something now. I want something today. There's over 200 experimental drugs for COVID-19. I've talked, I have friends in many universities around the country, and I'll say, listen, there's this drug, leronlimab. And they go, well, you know what? Why is this different than XYZ? We've had 20 calls and we don't want to go on a goose chase. And that's when my eyes really opened up and I said, wow. And then I realized, a lot of these small biotech companies, especially with COVID, everyone's got a publication and a study out. Everyone's also got a new medication out. You talk to these CEOs and their investors, and they're going to, not only is it going to cure COVID-19, it's going to cure cancer and HIV and extend everyone's life by 100 years.
Right.
So,
right.
And then you tell them, okay, listen, I'll get the drug. Well, it's in a computer model. You haven't developed it yet. Well, right, great. Right. What if that has no clinical relevance? I want to save patients' lives today.
Right.
And so that's why, leronlimab was an interesting drug. India also approved an interesting drug. And I've been telling people this. They are, it's a drug called itolizumab. And it was, it's a company called Biocon in India. I think this has really a lot of big implications here in the United States and a lot of the Western countries. This was the first monoclonal antibody that was approved for an emergency use approval by any government or any country in the world. And this was about 10 days ago. And I reached out to their chief science officer and I got a chance to, they invited me to their virtual press conference. I was absolutely impressed with this drug. It was approved in 2013 in India for psoriasis, and it's a monoclonal antibody to a molecule called CD6. And how that works, and the reason I want to bring this up is, again, people need to recognize that leronlimab is probably, in my opinion, the most promising drug. It's the granddaddy of them all. If the studies come out to say what it is with the strong science and with Dr. Patterson, the Mr. Miyagi of COVID-19 backing this up and everything is explained, this is the granddaddy of them all. I don't care what anyone says, but
it makes sense because it's really going at it's going at the attractor, as it were. But CD6 is an important modulator, a T cell modulator. So talk about that.
Yeah, so it's a really interesting. I love the science behind itolizumab. So again, we're going to talk about when those APCs, that antigen presenting cell of your innate system, when they're floating around.
So let me just say, it cells pick up a bad piece of protein and they present it to the immune system. That's antigen presentation.
Pretty much, right?
I mean, loosely speaking.
Yeah, exactly. It's I try not to get too technical sometimes, but sometimes
people are complaining we're going too shorthand. So I'm trying to stop us and explain. But keep going.
Okay, perfect. Yeah. So you've got two systems. The innate system, they're just basically, I guess, just running around. They're looking at people that are not supposed to be there, like the virus, like COVID-19.
Right.
Grab that virus, break it up, stick a piece of it outside, and this naive T cell comes in. Now, that connection between what's called a macrophage, that's that cell that's floating around getting the virus.
The antigen presenting cell.
And the antigen, right, exactly, the APC, the antigen presenting cell, and the naive T cell, they make a connection.
Naive meaning it's never seen that protein or that virus before. So keep going.
Exactly. So they make this connection. And it's almost like, they kind of like, I look at it kind of like they lock hands.
Yeah.
The hand from the macrophage is a receptor called ALCAM, ALCAM, and the T cell has the CD6, and they sort of have an affinity for each other. And there's a bunch of different connections that they've made. These researchers at Biocon, the quarterback in this situation is CD6, where they said CD6 by developing an antibody that can block CD6. We can then prevent that whole cascade of this cytokine or more
the heavy activation, the extreme activation.
Exactly, getting all the cytokine storms and whatnot. Very interesting. Of all these monoclonal antibodies, they're the only ones so far that have done a randomized control trial. Small study, looked at 30 patients in India. What they did was they took 20 were in their study arm, 10 were in their control arm. The dose is, so it's once a week. It's an intravenous infusion over 4 hours, 1.6 milligrams per kg, infused over 4 hours. And then they get it every week at 0.8 milligrams per kg over 4 hours IV. And what was interesting was in their control arm, they had 3 patients that died. In the study arm, all 20 patients, and by the way, none of them were mechanically ventilated. None of the 30 patients were. But so you're sort of looking at moderate.
Yeah, hospitalized, but not extremis. Yeah,
exactly. So all 20 patients were able to recover from COVID-19, and they were able to show the statistical significance of the efficacy, and said that it works. So
what is the name of the CD6 inhibitor? What is it?
So it's itolizumab, ITOLIZUMAB.
And I'm going to have to wrap things up in a minute here, but when is there is a placebo study coming out on leronlimab this week, possibly, yes? Efficacy at least.
Yes, we were thinking possibly today, but hopefully tomorrow, the next day, we will have those. I mean, we need those results to move forward. It's all about speculation and anecdotes now for the past 2 or 3 months. There's only so much anecdotes can hold you. So we need that data.
And then will you be able to use the drug?
Well, I think the idea is that if my theory is that if the evidence or the data is strong enough where you've got very statistically significant values and you've got an efficacy that, it's better than, to be honest with you, we're really always going to compare everything to remdesivir. But the reason this itolizumab from India is interesting is I feel like there's going to be a lot of comparisons between their findings and what any other monoclonal.
Right. That's what it sounds like to me. I think there are going to be 3 or 4 monoclonal antibodies out pretty quick here. And, these two sound the most promising.
And real quick, the other one that's of interest, I'll say real quick, is lenzulamab, made by a company called Humanigen. They have an antibody that blocks, their quarterback is GM-CSF. They've got a 12-patient study at Mayo Clinic. What's interesting about them is they have a phase 3 trial looking at 238 patients. I think the data should be out sometime in August or September. So that's another drug that I think is going to be quite interesting to look out for.
And that's a granulocyte stimulating factor.
It's a granulocyte macrophage colony stimulating factor, GM-CSF. What it does, it stimulates the myeloid line. So that's your eosinophils, basophils.
This feels like steroids to me. Sort of what steroids do, really. I don't know.
It really depends on what point. It's more it seems to be more upstream in terms of from the, you have your stem cells and then you have your 2 lineages, common myeloid and common lymphoid.
Yeah.
So it sort of starts to act a little bit more upstream than some of the other.
I guess that's true. It's more bulleted. It's more specific, and maybe with something like leronlimab or something, it would have powerful effects. Who knows?
Absolutely. I think some sort of combination. Again, we got to get the randomized control for each individual study first. I get it. That's sort of been the big challenge.
I get it. Well, listen, this has been fascinating for me. I think most of the people that have stuck around and watch are people that are very interested in this stuff, and they seem very appreciative. I think we've answered most of your guys' questions. If anything, Susan, the stream isn't running there. You have to go to the bottom. But if you have other questions, put them up there and we'll try to wrap this up. I really appreciate you coming on, and thank you for all the work you've done. My goodness. I mean, you've really, you've done your homework.
Well, when you got your friends that are literally dying on a ventilator in a hospital in Florida.
I get it. I get it. I've been fishing around myself, but I've not been as clear where to go. You've been a detective in terms of who to talk to and how to get the right information, because it's not easy to come by. It's not in the traditional literature.
It isn't. And one of the nice things I will talk about Dr. Patterson real quick, I talked to him yesterday and I said, you're probably the only physician and researcher that doesn't make me feel like an idiot. Like I talked to so many of my friends that that's not possible. It's not in the literature. I'm like, old paradigms for a new virus. Let's think outside the box. We have 143 million Americans that are dead. 3.9 million.
I absolutely agree with you. The traditional literature has been, I mean, I guess we'll see some of these placebo-controlled studies that are on clinicaltrials.gov, but we need biotechnology is what we need. And this is really biotechnological breakthroughs we're talking about here. And keeping your eye on what biotechnology is doing is challenging. It moves fast. It's not like clinical medicine. It's a little different. And you've sort of brought the two worlds together a little bit here, and I really do appreciate it.
And thank you very much for having me. You know, like I said, I grew up watching you on TV, so it's super cool getting a chance to talk to you in I know not in person, but at least in a virtual setting.
I feel like we spent an hour together. I feel like we were I mean, it wouldn't have been any different if we've actually been in person. Trust me. It'd be me listening to everything you're telling me and trying to learn and expand my understanding. Scott Taylor, I don't know what you've put in there. There's no way I can read all that. I think the questions are pretty much answered. Dr. Yo, thank you again. The website?
Yeah, so the website is the ECA Wellness. That's where I run my my sports performance lab. I'm on YouTube at Dr. Yo, and Instagram at ECA Wellness, and my Twitter is Yo Dr. Yo.
Yo Dr. Yo, and we will. I'll continue to watch and probably bring you back in a couple of weeks if you don't mind, just to give a little update on where this all is at. And I'm sure this is a changing landscape, and at least 2 to 4 weeks, things should be very different than now. And I would argue improved.
And I it's funny, almost every day. I would say that almost every day there's always something new that's coming up. Whether it's a couple of days ago is that the vaccine from England, they've said it's not really promising, and now everyone's waiting for leronlimab and keeping their fingers crossed. So yeah, every day something new.
I'm trying to sign up for a phase 3 on the Moderna vaccine because I can't get that fast enough as far as I'm concerned. So I've been making contacts there, and that's now a clinical application of a biotechnology that looks fantastic. And just to make the point, the safety profile is amazing. And just to make the point of how confident I am in it, and to also help me move the research forward, I'm happy to be a human subject. So I'm trying to get in there.
Well, a lot of these new vaccines, they're interesting. The platforms that are using the mRNA, the DNA, the adenoviruses, they're really fascinating. I love the science behind it. So it's again a wait and see. Even if it's quote unquote effective, we got to make sure those antibodies that people make are not only potent against the second or against COVID-19, but also that they are going to last how long they're going to last.
Well, they're about 2.5. They're about both the spike protein more traditional approach and the RNA approach have about 2.5 times the convalescent antibody response. But maybe you need to take them every so often. You know what I mean? Vaccines need boosters. That happens. We don't know. All right, sir. Thank you so much for being here. And I hope you'll be willing to come back because I'd love to update things for our viewers.
Oh, I would love to be back. It's always a pleasure. Thank you so much for having me.
All right, man. Talk soon. Thank you.
Thank you. Have a good night. Bye.
Good night. And those of you that have hung in here, you guys have done a great job of staying with the conversation. I've noticed there are people in here that clearly already knew the subject matter and are very interested in it. And I appreciate you guys being on the stream. And I think we all learned a bit here. I hope you understand now, get a sense of how complicated this cytokine issue is. Scott Saylor does mortgages. I'm trying to read all your stuff here, but I cannot. You distill that down to a couple of sentences, maybe. I can't read the whole thing here. It's just too much, and my thread's moving too fast. All right, I'm going to have to wrap everything up. I got to go do Fox 11 with my friend Alex Michelson. Susan, is there anything more from your standpoint? I can never tell which camera we're looking at here. That one.
You're good.
Anything more from your standpoint? Did you get all that? Were you listening carefully?
Yeah, I was.
What does CD6 cells? What is the CD6 receptor?
A lot of that is way over my head.
Oh, okay. It is. a physiology that was barely even on the radar when I was in medical school, and now it's becoming front and center. There are some good YouTube videos out there about basic cytokine activation and cytokine storm. If you look around, just look at cytokine storm or cytokine activation syndrome. Really nice, instructive videos out there if this whole thing seemed a little blurry to you. And really what we're talking about is just intervening in different places in that cytokine system when it becomes too active. There we go. Would Dr. Patterson do an interview, Mark? Maybe he would. I don't know. Maybe Dr. Yo can hook us up for that. I'm going to have to wrap it up, though, because I got to go meet my friend Alex. And we will see you tomorrow with Tyrus. And Tyrus is by himself, right? Correct, Susan? Good. We'll do a little more, maybe Tyrus's politics, things like that. There's a lot of political stuff.
Tyrus's rants.
Andrew also had another case for us. Yeah, Andrew, thank you for bringing in Dr. Yo. He has another recommendation for us. I emailed it to you.
He didn't call into my show last night.
Andrew Ashkazvili did not? Damn. Well, his wife was running his chat here yesterday, so maybe he was busy.
You know what's really funny? During my show, the computer shut down twice, and during this show, we've had no freezes.
Interesting. Well,
I know.
We'll keep talking
Colby
science.
She's just got some energy. Let me tell you.
And again, if you have any specific questions or people you'd like us to get into or other physiologies you want to learn about, maybe we'll get some vaccine paper. Yes, Laura, Dr. Zlenko is sick. He had a pulmonary artery replacement. His sarcoma recurred on his pulmonary arteries, so he has had a big operation.
Is he okay?
I just DM'd him.
You did?
Here's a thank God on screening what seems to be a recurrent pulmonary artery sarcoma attached to pulmonic valve, having surgery Thursday. And my resolve is unbreakable, and I will fight along as long as I can fight. That is Dr. Zelenko's words from us for today. Surgery for Thursday. He's asking for prayers. It's a big surgery.
We have a new BFF.
So I'd say surgeries, prayers for Dr. Zelenko. And my prediction is he will do fine with this surgery. I'm worried about what's going on, that this sarcoma is recurring. That's a bigger preoccupation of mine for Dr. Zelenko, but I'm going to predict it's a big surgery, but he will do fine. So we should hear more from him, probably be like Monday. All right, guys, thank you for being here, and we will be back again tomorrow with the great Tyrus.